Welcome to The Explainer. I want you to imagine you're sitting in clinic and a middle-aged woman walks in. She's exhausted, like bone-weary, crushing fatigue, and she is intensely itching all over. It's driving her absolutely crazy, especially at night. But here's the catch. When you examine her, there's nothing there. No rash, no bug bites, just the scratch marks she made herself. Months go by like this before anyone even thinks to check her liver. It's a classic hepatology mystery, and today we're going to solve it together.
It brings up this really fascinating paradox, right? Why on earth would severe itching leave absolutely no visible rash? Well, this exact question is the absolute key to understanding primary biliary cholangitis, or PBC, from first principles. If you've got severe itching without a primary skin issue, the trigger isn't local to the skin at all. It's systemic. There's something circulating in the blood that just shouldn't be there. And once we realize what that is, this whole disease stops being a random collection of symptoms and starts making total sense.
Okay, let's dive into this. To solve our mystery, we first have to recognize a really fundamental difference between a liver cell disease and a bile duct disease. PBC is an autoimmune condition, sure, but it doesn't actually target the liver cells, the hepatocytes, first. Instead, it goes straight for the small intrahepatic bile ducts. Basically, the immune system is attacking the liver's plumbing. So any liver cell damage or eventual cirrhosis you see down the line, that's just a downstream consequence of the bile not being able to drain properly. It's definitely not the starting point.
The actual microscopic lesion causing all this trouble is called non-suppurative cholangitis. Sounds like a mouthful, but it's essentially a highly targeted, T-cell mediated attack against the cells lining those small ducts. It causes chronic inflammation and totally destroys the bile duct architecture, but, and this is key, without any frank pus or bacterial infection, hence non-suppurative. The immune system is literally dismantling the liver's microscopic plumbing system piece by piece.
And this brilliantly illustrates what happens next. When you destroy the plumbing, bile flow gets blocked, and things start backing up into the bloodstream instead of safely draining into the gut. We call this cholestasis. So when bile acids accumulate in the blood, they irritate the peripheral nerve endings in the skin, which causes that intense pruritus, or itching. It's a circulating trigger. The mystery of the invisible rash is solved. Meanwhile, when cholesterol backs up, you get xanthelasma, those little yellowish deposits around the eyelids. And the whole underlying inflammatory process, that drives the profound, disproportionate fatigue, which honestly is often the most brutal symptom for these patients.
Now, you might also run into sickness syndrome with these patients. You know, that really gritty, uncomfortable dry eye and dry mouth sensation. But unlike the itching and the fatigue, this actually isn't a direct result of the broken plumbing or cholestasis. Instead, it just reflects the fact that PBC loves to cluster with other autoimmune diseases, especially Sjogren's syndrome. It's just a really important part of the broader autoimmune picture that we need to keep an eye out for.
Let's look at who's actually getting this disease. There's a staggering 12-to-1 female-to-male sex disparity in PBC. 12-to-1. That is one of the most pronounced gender gaps in all of autoimmune hepatology. So what you really should take away from this is to think twice before diagnosing PBC in a man. But on the flip side, you need to actively suspect it the second a middle-aged woman presents with unexplained itching, fatigue, or elevated cholestatic liver enzymes.
So, how do we actually confirm our suspicions? Well, we need to hit 2 out of 3 diagnostic criteria. First up, we look for the true serological hallmark, an anti-mitochondrial antibody, or AMA titer, of 1 to 40 or higher. This specific antibody targets the E2 subunit of the pyruvate dehydrogenase complex, and you'll see it in about 90 to 95% of your patients. If you don't have that, you look for an unexplained elevated alkaline phosphatase, at least 1.5 times the upper limit of normal, that sticks around for over 24 weeks. And finally, you can look for compatible liver histology, showing that exact non-spurative cholangitis we built out mechanistically earlier.
But what about that remaining 5 to 10% of patients who are AMA negative? Well, current guidance recognizes some highly specific antinuclear antibody, or ANA patterns, specifically anti-GP210 and anti-SP100. If your AMA-negative patient happens to have these, you can confidently diagnose PBC right then and there. No liver biopsy needed. This is a massive win for patient care, considering a biopsy used to just be the automatic next step.
All right, once we have a diagnosis, we have to talk treatment. Ursodeoxycholic acid, or UDCA, is our absolute first-line therapy. It has been the cornerstone of PBC treatment since way back in 1994. It improves liver chemistries, delays progression to advanced fibrosis, and crucially, prolongs transplant-free survival. But
We have to be real about its limitations. Roughly 15 to 40% of patients just don't get an adequate biochemical response to UDCA alone. Their alkaline phosphatase simply doesn't normalize enough. That means a huge, meaningful chunk of your patients are going to need a second-line option. And this is where we have a major, urgent update in how we manage this disease. For years, obeticholic acid was the standard second-line agent. But listen closely. As of September 2025, it was entirely withdrawn from the U.S. market. Post-marketing data showed cases of significant liver injury, so it's gone. That means a lot of older textbook teachings and even current study materials are completely outdated right now. Instead, to fill that exact gap, we are looking at the new PPAR agonists that the FDA approved in 2024.
So, the really crucial point here is, if anyone asks you about second-line therapy today, the definitively correct answer is the newly approved PPAR agonists, elafibranor and seladelpar. They are our new second-line champions. You use them in combination with UDCA for those who didn't respond enough, or as a monotherapy if a patient can't tolerate UDCA at all. And honestly, here's the best part. They don't just make the lab numbers look pretty, they actually have favorable effects on pruritus. They directly help alleviate the most burdensome symptom, the itching itself, rather than just fixing the enzymes while the patient continues to suffer. Speaking of suffering, if we need to target that relentless itching immediately, independent of those disease-modifying drugs we just talked about, we have a dedicated symptomatic ladder. We start right off the bat with cholestyramine. If that doesn't provide relief, we escalate to rifampicin. For the tougher cases, we move up to the opiate antagonist naltrexone. And finally, for truly stubborn, refractory itching, we try sertraline. Having this ladder gives us immediate, actionable ways to help patients get their sanity back.
But beyond just the liver and the itching, we have to manage the whole holistic picture, right? We have to handle all the downstream systemic consequences of that bile not flowing. We use artificial tears and moisturizers for the sickest symptoms. We use statins to address the hyperlipidemia, though, quick side note, absolutely avoid oral contraceptives because estrogen can actually make cholestasis much worse. We also need to aggressively replace fat-soluble vitamins A, D, E, and K because if bile isn't flowing, fat isn't absorbing. We absolutely must order DEXA scans to prevent osteoporosis since chronic cholestasis carries major bone health risks. And naturally, if cirrhosis does eventually develop, we immediately start standard hepatocellular carcinoma screening.
We've covered a ton of ground in this explainer today, but it really all comes back to one core foundational idea. So to wrap things up, I'll leave you with this. If you see invisible itching, what is backing up in the blood that shouldn't be there? When you take these miserable, seemingly disconnected symptoms and trace them all the way back to the broken plumbing, back to those bile acids spilling into the blood because the microscopic ducts are under attack, the entire clinical mystery of primary biliary cholangitis just solves itself. You literally just have to follow the flow. Thanks so much for joining me for this explainer, and keep asking the right questions.